You're listening to RideAlong, EMT School. I'm Mike.
And I'm Max. We're two students navigating EMT school, bringing you along week by week.
And I'm Jonathan, a paramedic bringing real-world perspective.
Join us as we share the lessons, challenges, and stories from EMT school, and hear insights from those already living the EMS life. Welcome to the RideAlong. Insights from those living the EMS life. That's why we have Jonathan here.
Oh, man.
Although, yeah.
You guys are getting some exposure through your clinical ride time.
It's true. I mean, welcome everybody to the RideAlong EMT School podcast. We're just going to jump right into this thing like we normally do, into whatever random conversation that we were looking to have. But yes, I have. So funny enough, I had a bit of a dry spell going on. Like I took like 38 hours worth of shifts of volunteer time. And finally yesterday I had some action, which is it's so weird to think about that because like I in my head, I'm trying to rectify that. Like, I don't want to be excited for like somebody having a bad day, but at the same time, it's like that me wanting to see and experience things has no karmic effect on whether or not that thing's going to happen in the first place. It's just whether or not I'm there for it, you know?
I mean, whatever somebody's got going on is going on regardless of you, like you're saying. So you might as well be the one there getting the experience.
Right.
And
I might as well learn from their bad day.
Yeah.
I'll use that one to comfort them next time. Like, hey, listen, I know you're not feeling really great with like your seizure that you just had, and you're feeling kind of nauseous, but just so you know, I'm learning. Like, I'm learning from this. And you should feel good about that. It's like,
a lot of the times I tell people, it's like, hey, because I'll, especially in my role now, I have a lot of time to like talk to people and they're not having a good day, right?
Oh,
they're interacting with somebody on an ambulance. It's not a good day for them. But a lot of times, because of the length of time I get to spend with them at this point, it often is a pleasant conversation, and just to be able to say, "Hey, I hate the circumstances under which we met, but I'm glad I could be here to help you out."
Yeah,
like, and I tell people that that's what we're in this for. We're in this to help people and provide care to them. So, and especially for you as a student, you got to get this experience.
Oh,
man.
yeah.
Like, it might as well be you.
And I have to get 10 of them, like per Pennsylvania, guidelines.
Yeah.
I have to get 10 patient contacts. And while I'd had a bunch when I first started volunteering, technically I wasn't released, quote unquote, to actually get those patient contacts until a certain point. And even after then, I'd had a couple, but I didn't feel confident enough to write them down because I felt like I was just kind of like, an ornament on the wall in the ambulance, and I wasn't really like feeling like I was helping, although I should have counted them. That's besides the point. But I was like, oh, I'll get plenty of these. They'll be coming. I'll have to like throw some away, and then like I had 3 shifts in a row where I'm like, oh, I need all of these.
All of them. And I told you guys.
Yeah, I know.
I've had students ride with me and they get all their calls immediately. Like I had some students really on their first shift knock out about 8 of their 10 calls that they needed. Yeah. And then now they of course are the way our programs run, that I'm a part of, they get more ride time than that. Like if they were to just catch all 10 of their calls in one shift, they would get more ride time than that because they need the additional time. But man, some people just struggle. I watch people struggle. They will sit there and won't turn a wheel for 12 hours or it's rough. And I mean, going through paramedic school, it was like that for me. I chased calls as much as I possibly could to get the things I needed to get.
Yeah.
So
I mean, I got some valuable experience sleeping, on a chair in an ambulance squad. Like did a couple of overnight shifts to try and catch anything I could. Not a lot goes on at night. When it does happen, they need you there, but it's not the busy time.
just wait until you don't need calls.
I know,
then,
and then
you're gonna
I'll be
you're gonna be
fending
swimming
them
in
off with a stick. But it was. I finally, so after 3 shifts, no calls whatsoever. I finally broke my white cloud curse, and I had 3 yesterday. One of which we're going to talk about on the next episode. So next episode, we're going to be talking about overdoses and I think it's overdoses and poisonings.
Yeah.
So stay tuned for that one. Like if you want to hear a good story, a story of my first code, the first time I went responding to a cardiac arrest or called in as a cardiac arrest. It's a more complicated story than that, but I'll tell it on the next episode. And then I had a couple of calls yesterday for an old lady with COPD who fell and was having some trouble breathing from a broken rib. Well, field impression of a broken rib. Obviously, we cannot diagnose things, but pretty sure she had a broken rib. And then a young man who was postictal and had a seizure, and good learning day. But I'm really learning a bunch. But I'm at 4 now. I'm at 4 total contacts of my 10, and a couple more months to go. Technically, like about a month left to get my time in.
Yeah, I wish you the best of luck.
Thanks. Yeah. I keep telling, it's funny because we chat in between, and I keep telling Jonathan and Max, oh yeah, I've got things this is what happened. And Jonathan keeps saying good luck, man. I wish you a quiet night, which I know is your way of saying, I don't wish you a quiet night. Cause it's kind of like break a leg, but it was rough.
Yeah. Yeah, if you're trying to get calls, that's the only time I'll use the Q word.
Yeah.
We're a superstitious bunch.
Yes. But, speaking of Max, he's not here. We're flying the missing man formation this evening for this episode. Max, you will be missed, sir. Hopefully he will be joining us again for the next episode where we're talking about poisonings and overdose. But Max has some family stuff he's taking care of, and we wish him the best and to his family. But we will not be graced by his lovely presence this evening, unfortunately. But we're here, missing man formation. So what you got going on, Jonathan? Anything good?
Oh man, so we're talking about the big sepsis and infectious diseases tonight.
We are.
And
it's a fun topic.
As we delve into this, I have a story from this past week of somebody who met a sepsis criteria.
Okay.
And was having some issues with related to that.
Really?
Yeah. So he had a lot going on. He'd had some surgical procedures that he had scheduled and had one of the surgical procedures done, and it didn't go so well for him. And then the next day he woke up with aphasia, right?
Oh, yep.
He had the word salad. You'd talk to him and he was there. He knew what was going on for the most part, but he could not get out the proper words.
Yeah.
Couldn't tell us his name, really. Couldn't really articulate anything. But if you asked him yes or no questions where he could nod his head or shake his head, yes or no, he could answer questions that way. So
interesting. So it's just a language center or something that was blocking his ability to say the words.
Right. But he also triggered a sepsis protocol. He had a fever. He had, again, a known source of infection. And he started to have profound hypotension. So Yeah.
Well,
And
all
so
of which are some key factors that we're going to be talking about tonight.
right. So as he started to get hypotensive, I had to intervene and do some paramedic things, and got to give some drugs that I'd never given before, and got to see the positive effects that it helped as far as his condition. And it was an interesting call, to say the least. Spent about 2.5 hours with him on a transport.
Okay, so that was a transport call, wasn't not 911.
No, not
Okay,
911. Yeah.
gotcha.
So, uh, and I mean, like, I'm learning a lot, right? Most of my career's been spent in 911, but doing this travel contract thing, and a lot of it's interfacility transport, and man, I'm spending a lot more time with patients
Mm-hmm.
and getting to watch their vital signs truly trend particular directions, and that's what was happening with him. His pressure started to trend down, and it got to the point where I was like, no, we're gonna fix this.
Yeah.
And in a span of about 15 minutes, I was like, okay, let's see what the next blood pressure cycles to. And it just kept going lower and lower. So he got some drugs to fix that.
What you mean to raise somebody's blood pressure? You don't just like yell at them like incendiary remarks or like make them angry. Like
I think he was past that point. I've had that happen. I told a guy one time, he was very sick. He was bradycardic in like the high 30s.
Okay.
And I was like, "Hey, buddy, I'm about to put these pads on you, and you're about to have some electricity going through you as I pace you, and it's not going to feel comfortable." And his heart rate started to come back up as we just the stress of that. But I mean, I was very worried about that guy too. So, but yeah, that's kind of what I got going on.
Nice.
Just I'm getting in the mix of things, learning. Right, you never stop learning in this, and
yeah. I had a few people tell me, because I obviously shared my story around of like, hey, I'm 36 hours in and I haven't had a single call at 2 different EMS 911 agencies, and they're like, hey, you should consider reaching out to like transport agencies in your area, because you'll like it's obviously more scheduled. Like or some of it is like, hey, people will be transferred. We do that. I mean, granted, there's an aspect of that that's could be hit or miss in terms of catching a call, but the it's more stable. And then you get the like pretty much guaranteed, hey, we got to get this patient from here to here,
right?
And we got to get a contact. We got to get information. We got to assess them start to finish, and you get some handoff practice and stuff. So like I was like, that might be one of my next steps is to reach out to one of those organizations and see if I can, and even just to see it from that angle too, see what it's like to do the transport gig,
right?
Because I like seeing all the different aspects of this EMS stuff. But yeah, so the whole nother aspect of EMS is the transport side.
Yeah, and I mean it's a lot of people like the action of 911, which it's a lot of time it's not action. A lot of time it's dealing with maybe what we wouldn't consider an emergency in our minds, but still dealing with it nonetheless. But on the transport side, man, you get to see some really sick people and you get to sit with them for that extended period of time. And so managing those people and just the logistics that are involved in there's a lot of learning that can occur.
I can imagine.
Yeah. So
cool stuff. Well, I mean, so we've been, you mentioned before, obviously this episode is, come on, get up, get down with the sepsis. Another another music reference there to some would say that sepsis can be disturbing.
It can be.
Am I really
You're reaching, brother.
I'm hitting these dad jokes too hard. But no, like obviously this week's about infectious diseases and sepsis. So normally we'll take like a small term and kind of break that out as our medical term of the week. But this week, because I really wanted to dig in, it's like, what is sepsis? Because even going through it in class, they go through all this stuff, right? They talk about, well, okay, here's the definition of sepsis. So the definition is it's a systemic, dysregulated response to infection that leads to organ dysfunction, hypotension, and potentially septic shock.
Right.
Okay, that I think I understand all those different parts, but like part of me was going, but what is it? Like for something like heart attacks, myocardial infarctions, right?
Right.
We got to break some of those things down and start understanding what exactly it is. So like, oh, that's a blockage in the vessels that lead to the heart tissue. Okay. All right. I can wrap my head around that. So I kept trying to figure out like, but what is sepsis? Like what is it? And there really, like at the end of the day, there wasn't really a definition or there wasn't really an answer. And that I found interesting because it's not necessarily a definitive thing. Like you don't have a sepsis virus. You don't have a sepsis bacteria.
Right.
You don't have like, the sepsis deformity in your heart or whatever. It's literally this combination of things that happen. It's almost like, actually as I was reading into it, it's kind of akin to the anaphylaxis. Where
that's systemic response.
It's a systemic response to infection that is going haywire, right? So it starts from an infection, usually something that is internal, like deep seated within the body. So like kidney infections, pneumonia is a big one that leads to it. These types of like infections that are kind of not surface level infections, right?
Sure.
And it could even be something that starts at the surface, like a like a cyst or like a fistula, I think is the term, but like where you have an infection of like a port or something that is going through the skin into the rest of the body, right?
It's fissure.
Yeah. So like, but like an infection of a port that's going into a vessel, like for dialysis or something like that.
Right. The fistula is the access for the dialysis. Yeah.
So if those things get infected, they're kind of like direct access already into the body, right? They're these things that are like leading infection all the way right to an organ almost. Or like a big one is a catheter. A catheter going into the bladder is kind of an easy vector for infection to go up into the kidneys to create a kidney infection or
urinary
tract infection.
Yeah.
So all these things, left unchecked, if they're not being treated, or even if they are being treated, sometimes they can lead to this kind of systemic response to an infection, which is kind of the body going haywire, right? So the infection triggers systemic inflammation, not just at the location that it's happening. It starts happening everywhere. And then you get this kind of widespread vasodilation, which we saw as part of anaphylaxis too, right? The blood vessels around the body start getting leaky to increase like blood flow around the body, which is good to treat infection, right? You want blood flow. We learned that. Blood flow helps like, defeat and fend off invaders. But when it starts happening everywhere, it's not getting to the spots that need it. And it's lowering your blood pressure, right? And it causes capillary leak, causes poor perfusion because all of a sudden your blood's kind of leaking out everywhere into the rest of your body. And then that leads to poor perfusion. Poor perfusion is shock. And that's kind of how you get to sepsis shock, right? So, the pathophysiology of sepsis is really a story of, well, this is supposed to happen, but not in this scale. Right. Not everywhere all at the same time.
Yep. Yeah, the scale is really the biggest thing, right? Localized infections, right? You get that inflammatory response, and that's what we want. Right? But if it happens for too long of a period of time or too great of the body's or too large of an area of the body, that's when we get all those signs and symptoms that you just talked about, and yeah, ultimately poor perfusion. Septic shock is a form of distributive shock,
Mm-hmm.
so just something to keep in mind.
And then I thought this was interesting too, because I remember when I was a kid, my parents or the older generation referring to things like blood poisoning.
Mm-hmm.
And that always stuck in my head. And then I remember at some point hearing the term sepsis and then always thinking those two things were maybe related. But then,
Right.
it wasn't until this kind of just recently where I really thought about it. I was like, okay, so what is blood poison? It's the same thing. So what they used to call blood poisoning was sepsis. And when you think about it, it makes sense because like they're saying, oh, well, it's blood poisoning, right? Like it's all around the body. It's an infection everywhere. And yeah, that's true, but it was a misnomer because it wasn't necessarily an infection of the blood, because technically whenever you're infected, there's always infectious material in your blood, right? So, but it's really a definition more of the body's response to that infection. It's not necessarily like it's in your blood. It's just, it's everywhere. The infection is being kind of felt throughout the entire body. Right.
Yeah.
So that was where the kind of misnomer of blood poisoning came from back in the day.
And I mean, even a further terminology to relate more to that quote unquote blood poisoning, septicemia.
Septicemia.
Right? Septicemia. Right. Right. It's just a massive infection in the bloodstream.
Mm-hmm.
So, but yeah, I mean, that's what it is, right? That's the old terminology to the new terminology.
Yep.
Septicemia.
And sepsis is something that, like, we've realized is so important to the story of EMS and well, just in the pre-hospital care of people in general, because
right.
It is so important to even the post-hospital journey and in hospital. Like, sepsis is a kind of constant threat for people who have any type of sickness or infection that's going on. It can lead to sepsis. So what's our role? Like, our role on the EMS side, you mentioned it before, Jonathan, like, cause like this is, sometimes you run across these things in EMS where you're like, well, what can I do about it? I really, it's, it feels so overwhelming that it's like, well, I don't have things that I can give to somebody. I don't have massive amounts of antibiotics, right? Like broad spectrum antibiotics or all these things that they'll give to them in the hospital environment.
Sure.
Not that we would even know what to give them, but our job really isn't necessarily the treatment, because what we've talked about a bunch of times is like, we're the eyes and ears, right? Like, that's where we come in, is spotting it.
Right.
Like,
and that's the important part, right? That recognition, to kind of, as we were talking offline before we started the podcast, I remember at the onset of my career and many, many years into my career, we like sepsis was something like that was mentioned, but it wasn't something pre-hospitally we were really as interested in. And then probably about 10 years ago, I started to see that trend shift. And then as we've continued through that 10 years, it's become a bigger and bigger and bigger deal for us on the pre-hospital side of the house, and as far as recognition, and then early alert or alerting hospitals or definitive care that, the person we're bringing in probably is going to trigger a sepsis criteria or sepsis protocol. And that, what that does is it gets them more resources more quickly. We've talked about that kind of thing with, with cardiac. We've talked about that kind of thing with a stroke. And this is another one of those things that on the BLS side, just that early recognition helps boost positive outcomes. The sooner we can see it and recognize it and get some resources towards that person, the better outcomes they're going to have.
Yeah. So. I'll even throw in there the, like, while we are the eyes, like we're helping spot these things that could be red flags for sepsis. Like the kind of, understood aspect of our jobs is that we're also the communicator, we're the patient advocate, right? So that aspect of, being that person that can call and articulate all these things that, are kind of ticking certain boxes, like,
Right.
hey, I have a sepsis, like this is a sepsis alert. The, temperature is a certain amount, low blood pressure, all these factors that we're looking for together to go, hey, those add up to like possibly being sepsis. And even if it's wrong,
Right.
who cares? Like, I'm sure somebody cares, but I think it's, way better for us to like properly look at these potential red flags,
Right.
call it out for what it is, and then give them the heads up at the hospital so that there is no delay, or it's a greatly reduced delay in terms of getting, care for somebody who could have sepsis, which could include those things that we talked about before in terms of antibiotics or other treatments, things that they're like, hey, and getting, that patient into a kind of like environment where they're likely to get less like infections, like, it's because it's not just treating the infection that's there. It's also limiting what could be affecting them more, or that infection spreading to others as well. Right. So you gotta,
and like, I think one of the first things that, or I know one of the first things that somebody's going to get when you call a sepsis alert, your standard blood work does not include blood cultures most of the time. But as soon as you trigger that sepsis alert, as fast as possible, because hospital systems are really, hammering this, they're going to get blood cultures drawn, and that's going to be an additional test for them.
Yeah.
And then probably if it's highly suspected, even before blood cultures have come back on that lab work, they may even get antibiotics prophylactically started. So, I mean, it's, it's important. And the cool thing about EMS related to this and a lot of conditions, most of the time we only have one patient in our ambulance at a time. Most of the time. Sometimes it's so that's probably the only time that patient is going to only have that much focus on them, because of staffing issues and ratios. Like, most nurses have more than one patient. The doctor has all the patients in that they're assigned. You know what I mean?
Yeah.
So, so it's really an opportunity for us to find that. Yeah. Hopefully,
like we have, maybe we'll call it 30 minutes to maybe over an hour, one-on-one patient care.
Sure.
And where else does that exist in the healthcare environment, really?
It's something that's rare and rare as we go on.
I would actually say sometimes that ratio is even higher, because like, while you may have a lead, like if like when I'm rolling around, it's like 3 people in an ambulance, right? So that's 2-on-1 direct patient interaction, like 2 providers. Well, I guess if you can consider me a provider at that point, but like, 2 people dedicated to your care.
Right.
For however long it takes to assess, transport, move them to the hospital, do the handoff, and sometimes 3, like depending on, how many people you got on that ambulance for the day. So it's like there's a lot of attention being given to one person, and that's where you get to take advantage of it, right? Getting all the information you can, doing whatever you can for them to stack the deck in their favor.
Yep.
So, absolutely. I thought it was super interesting, and like how important it was for us to kind of get there, even if we're not providing treatments, but like there are things that we're obviously doing too, for those sepsis patients. We'll get into treatment later, but once they get into the hospital, there's a whole host of things, like you mentioned, blood cultures, things like white blood cell counts to see infection rates. There's a whole host of things that I'm not even going to necessarily go into here, just because they're more advanced medical, like, assessment tools, like, that require like hospital level stuff. But to reiterate that, like, none of those things comes back with like a result that says like 100% guaranteed sepsis.
Right.
All of them are leading to this kind of like cumulative assessment on the side of doctors that are saying like, oh, all these, like 7 out of these 10 boxes are being checked. They have a worsening infection. It's sepsis. We're going to treat this as sepsis. It's going to be sepsis. Like, there's nothing that comes back that's like, yep, this is 100% sepsis. It all stems from some other infection in the first place, and then it's just, throwing the body haywire.
Right.
However, there are some assessment tools that even in the field we could rely on to help us kind of understand whether or not sepsis is more likely. The biggest one, and there's a few of them, but the one that we learned in the book is called SIRS, which in this particular instance, I don't even know if I'm sure it has an acronym, but that acronym isn't based off of the things that you assess. It's like, it's temperature less than 96.8 degrees. So like hypothermic, or over 101 degrees hyperthermic. So like if you're off normal body temp, either low or high,
right,
you have a heart rate greater than 90,
right,
a respiratory rate lower than 20,
would be higher than 20.
Is it higher than 20? I might have.
Yeah, it'd be higher than 20.
Okay, higher than 20. And then a systolic blood pressure lower than 90. If you have any two of those things, and altered mental status.
Yep, altered mental status is the big one.
So those things. So temperature, heart rate, respiratory rate, blood pressure, altered mental status. If you have two of those 5, that's kind of like the red flag, like combinations of those things.
And so SIRS criteria, or systemic inflammatory response syndrome. This is the criteria. Yeah, this is the criteria that we're looking at, or the all the things Mike just talked about. Those all encompass SIRS, and that's a great assessment tool to kind of go ahead and make a determination to call that sepsis alert. Again, and I mentioned it earlier, something additional to that is that known source of infection.
Mm-hmm. Yeah,
that known source of potential infection, I should say.
Yeah, like if they're like, oh yeah, I had a bladder infection, like I was under treatment for, and then you're seeing all these things, it's kind of like, oh, well then it's huge. Like that's like we need to certainly call in that septic alert or sepsis alert. But I kind of went a little deep too, because I was like, oh well, I wonder, like in the grand scheme of things in the world itself, like what role is sepsis playing? Because I'm like, wow, I never really truly understood that it was this prevalent or this like important for us to keep an eye out for sepsis. Like I'd heard of people getting sepsis, obviously, like, oh, well, they went into the hospital and they got sepsis. Totally not thinking that it's like likely a thing that happens outside of the hospital from an infection too. Like like I said, just things that are challenging my preconception going into emergency services. So like apparently sepsis is one of the leading causes of death worldwide.
Yep.
It contributes to roughly 1 in every 5 deaths across the globe. 1 in 5, 20% of deaths across the globe are either because of or closely related to sepsis. Granted, that is much less here. Like that is not in the United States. We are not at 20% of like sepsis, like, people dying from sepsis. Unfortunately, it's much more in undeveloped, poorer countries, places where there's less access to healthcare. Like sepsis is the thing that's killing a lot of people.
Less access to, clean drinking water and just, they
get infections on the regular, right?
Yeah. Yeah.
Or bacterial infections, things that that is considered part of their life because they just don't have all the modern, amenities and privileges that we have in our world.
Right.
Of like, oh yeah, like I take clean drinking water for granted a lot.
Yeah. or just, waste management. Like, there's across the globe, lots of places that don't have, waste management, whether that be, plumbing or whether that be just garbage pickup. Yeah. I mean, but those conditions lead to potential disease and infections.
Yeah. exactly. So it's crazy because sepsis kills more people than breast cancer, prostate cancer, and HIV/AIDS combined, like across. Like, damn, that's pretty crazy. As a matter of fact, I also found something in there too, because I remember being a kid and hearing about the first time I ever heard the word sepsis. Do you remember the first time you heard it?
I was probably working in healthcare.
Okay.
To be honest.
Because I just remember this moment because it was like it was pretty impactful for like me as a kid, because in 1990 I would have been about 5. So hearing a term then would have been like, it may have stuck with me. And I think that's kind of the first time I heard like the word itself used. And it was from one very particular person dying, and that was Jim Henson. So the creator of the Muppets, he in 1990 developed sepsis, and that was kind of, I think, widely known there. I remember hearing it, that he died from that, and thinking of it at the time like, oh, that sounds like a terrible, rare disease. But no, it's not. It's like the guy died because he his infection just got worse. So he had pneumonia, which led to sepsis. And it shocked the world. Like everybody, I remember a lot of my friends, and like I still have friends that like lament, like, because he was such a huge part of like Sesame Street and the Muppet Show. Like it's it's part of if you grew up in that era, you were very heavily influenced by Jim Henson. But there have been other people too. I mean, it's killed like millions upon millions of people throughout history. So another big one was I know this like my grandfather and like his generation were very much big fans of like Pope John Paul II. Right. So and this one's kind of interesting too, because like he was really old. And old people get all different types of things that lead to death. Unfortunately, it's just, part of life. Yep. But his death in 2005 really led to a lot of discussions as well, in terms of like how that kind of older generation is at risk of sepsis. So it really, I think it raised some of that. I remember it being talked about some when he died, but it brought a lot of attention to sepsis as a lethal complication in the elderly. So.
Sure.
And there's a host of other people too. Like obviously it's so prevalent that like many people throughout history have died from sepsis. But that was interesting. And then I also kind of took a little bit of a deep dive into some statistics in terms of war and like combat, which a lot of what we do in the EMS is kind of derived from battlefield medicine, right? Like that was kind of the impetus for some of the techniques and rapid transport and, things that we learn in EMS. A lot of it comes from that world. So sepsis has been a huge player in casualties in warfare, right? So in the Civil War, and I'm sure the numbers are even worse if the farther back you go, but I got some kind of statistics from the Civil War where out of all casualties, all injuries in the war, something between 40 and 60% of those casualties had died. Sorry, out of all the casualties, 40 to 60% died from sepsis.
Right.
So like the idea of an infection just eventually running wild, like the body not being able to overcome it, and it just leads to overall, widespread systemic infection, and they die.
Yeah. 60%
of people. So like, and that counts for like, oh, I fell and broke my leg walking to like, not even just from the bullet wounds or the traumatic
a broken leg, could lead to sepsis in those instances. Yeah. It's, a case study that I remember from high school. We were talking about medicine during the Civil War, and the northern troops, the doctors there, they had a higher mortality rate due to infection than the southern southern states medical providers, and what it came down to was, so the North had their sutures for closing up wounds. They had them made out of silk, and they were more expensive, and they had access to them. But then the South, what they would use for sutures, because they didn't have access to that stuff, they had horsehair. But the horsehair by itself was a little too brittle, a little too tough to to use the sutures as it was, to come like straight off the horse. So that a doctor just he just tried this out to see if he could, make them a little more supple to use. They boiled them, and in a way, that was a form of sterilization. So they were sterilizing their sutures before they were using them, and then they had more positive outcomes for injured soldiers in the South. It's kind of an interesting thing, right? That's more of like a retrospective case study of like, well, what were they doing differently?
Right.
But that's like one of the first instances of sterilization in battlefield medicine. So I thought it was neat to hear about.
It's kind of like, oh, well, we found out that like alcohol, like ethanol was a disinfectant because we just thought it smelled good and we just sprinkled it on everybody. Like, we're just using it for something completely different.
Right.
I thought the North had poor results because they were obviously wrong. Being from the South, I was hesitant to even use the term Civil War because everyone knows it's the War of Northern Aggression.
Oh, jeez.
No, I'm joking.
Yikes!
I just like to pick on Jonathan and his sultry Southern draw. Like you're below. Is Virginia below the Mason-Dixon line? It is, right?
Either way. So, regardless of who discovered this, the fact that some level of sterilization was occurring,
and even on a small scale, was getting good results.
They were having better results. That's amazing, right? And it kind of, it's one of those stepping stones for us in medicine that, if we have these things that are clean and sterilized, we get less instances of infection further down the line.
I think that was probably one of the biggest things between, say, the Civil War and World War I, where, and also I would say, that was kind of the start of modern ambulance services, right? Like World War I, they really amped up the idea of transport, rapid transport to medical care.
Well, and the French even, and I don't want to talk out of turn, but the French even had ambulance corps post Civil War, but going into the Napoleonic Wars,
Napoleonic Wars were
they would have the ambulance corps that they would come and get the casualties off the battlefield.
Right.
So.
Well, I think the big thing about this the World War I was, at that point we're starting to see a lot of proliferation of faster vehicles, right? And things that are, we don't have to rely on horses to get people everywhere. And you can have more centralized logistics, right? So in the Civil War, where it was like 40 to 60% of casualties that were dying from sepsis, it starts going down in World War I, and you're looking at like 15 to 25%. And that, that's kind of, where we started seeing things in almost like like the introduction of aseptic techniques in certain circumstances, which I'm sure brings down things dramatically. Hey, we saw it, unexpectedly and without necessarily trying with boiled horsehair. They're specifically trying to do it. So that's starting to bring down some of those results, some of the bad results from sepsis. And then you start seeing, a few more years later, a couple decades later, you get into World War II, and it's, basically I saw some numbers that broke that down into pre-penicillin and post-penicillin, where pre-penicillin, we're looking at like 10 to 15%. So, still trending positively. And then past, the most ubiquitous antibiotic known to man, penicillin, you're looking at less than 2% casualties developing sepsis and dying. So it's like huge. So that's like those things. Oh, and then anything beyond that basically falls under like 1%. So anybody who gets, is a casualty in, Vietnam or any of the modern wars beyond there, you're looking at less than 1% of casualties developing developing sepsis and dying. So, and that's really from the rapid transport and rapid transport to advanced medical care,
Right.
Aseptic and sterile techniques in that pre-hospital environment, and the use of antibiotics. We on the modern EMS still do 2 of those things,
Well, and on the ALS side of the house, we even have antibiotics that we can initiate.
Exactly.
Yeah. So I mean, like, we can do all 3 of those things at the proper level of care.
Yeah. So really, really effective ways to help kind of people that are suffering from sepsis, right? So I know this was a pretty deep medical term of the week, kind of seeing all the different aspects of sepsis, but that was a huge topic. And then like it requires understanding a few different things and kind of talking through some stuff. So, and I'm sure we'll chat about it a little bit more as we go through some of our other topics, because basically every infection can lead to sepsis. So we're always looking out for that progression. But yeah, so that was the medical term of the week, sepsis, which only took like 40 minutes to get through.
No, it's interesting stuff though. It's led to, some good conversation.
Yeah.
So hopefully it was beneficial.
I hope a lot of people are kind of like, we see the numbers, like, our analytics, like as being the producer of the podcast, I like to try and keep an eye on the numbers, and people are listening. And like, I'm super jazzed to know that people are finding value in this, and that like, I'm hoping this is helping some people kind of get through school. 'Cause that's what it's been for me, is like really this at its core, this has been, well, my therapy session, where I unleash all of my frustrations on Jonathan and tell him, why didn't you warn me before getting into all this?
I did.
He did. He did warn me. And for Max and I to both kind of, stare at each other and go, what did we do that? Why are we doing this to ourselves? But really it's turned into a fantastic study guide in terms of like really helping solidify the concepts and at the very least the didactic side of EMT. Like there is no substitute for getting out there and doing the EMS volunteer stuff, like getting onto an ambulance, working with people. You have to do that. But there's this kind of learning side that like you have to it's really the understanding, right? You can memorize all the answers you want. You can memorize terminology. Memorization is great, but understanding is the best. So like, and I find that getting to talk to you guys about it and kind of articulate it and understand it and chat about it and go, oh, you know what? Oh, I'm wrong. I had a wrong understanding of what that was. And like, it's now this, and that's super, super invaluable. I think it's great. So hopefully people out there are enjoying it. But yeah, so the rest of this episode is devoted to infectious diseases.
Yeah.
Just like the rest of my own personal medical records. And no, I'm joking. It's always rough coming home from Las Vegas and explaining to your wife while you have a prescription for, I don't know. I'm trying to make like a bad venereal disease joke, which they don't even call it venereal disease anymore. Now it's
that's funny.
Communicable diseases. But yeah, so that's what we're talking about, is infectious disease. What is an infectious disease, Jonathan?
Oh man, so it's anything that is caused by a microorganism, virus, bacteria, fungi, or parasite.
Yeah, I'm a fun guy. They tell me that.
You are a fungi, but I wouldn't say you're a fungus. So usually these are spread through either direct contact, indirect contact, meaning like you've touched something that somebody who has this
Yeah,
communicable disease.
secondary. Yeah.
Yeah. Airborne or droplets. And then vector borne, which is is something like a tick, a flea, a mosquito, um, and then other bloodborne pathogens, right? Direct contact with somebody's body fluids via your mucosal membranes or
Mm-hmm.
some sort of entryway into the body, like a cut or
Yep.
something to that effect.
I remember the first time I ever took bloodborne pathogen training. Like,
Hmm.
I hated it, man. Like, I did it. I did as in the Boy Scouts. Like, I at one point I worked for the Boy Scouts. Like, I was a summer camp staff employee, and every year we had to take the obligatory, like, training videos where it's like, now we're going to talk about bloodborne pathogens and make sure
Yeah.
that you just stand far back from everybody. And I even remember all the bloodborne pathogen stuff, but some of it makes it so dry and you don't understand it.
Yeah.
But putting it into the context of EMS, it's like, it's essential, right? Like there's so many different ways that we can kind of, you know, be exposed to these infectious diseases,
Right.
right?
Yeah. And I mean, the big thing is like to continue to provide care to all the people we're trying to provide care to, we have got to stay healthy. And to stay healthy,
Yeah.
we got to do some things to do that.
Obviously,
So,
we have to leave, right? Like we just hightail it out of there.
Sometimes that is the answer.
I'll just travel to some other state and just be like, nope, and I won't be around people today because I just don't want to. No, it's like we can't really do
Right.
that. Like we're at a certain point, we become obligated to help.
Yeah.
We're already there. We have some tools at our disposal though that we could use to like limit our risk, but
Right.
at a certain point, like, the medical world works. It keeps working regardless. Like we still have to help people that have diseases, that have
Right.
infections. We just take some precautions with it. We'll talk about those, but I think the biggest thing to kind of start with is the idea of like communicable versus
Mhm.
non-communicable,
Right.
non-communicable.
Right.
And really those things being, they're a defining factor for certain things. So like communicable diseases, those are the ones that we worry about the most.
Right.
Like, cause those are the ones that can spread from person to person.
Mhm.
Right. That's your viruses, your bacteria, the things that we worry about. Is why we wear the protective equipment that we do.
Right.
And then there are non-communicable diseases. So
Right.
things like tetanus. Tetanus you
Yeah.
don't get from another person, you get from like a rusty nail, right? But that can still be a communicable or not. Sorry, it's a disease, but it's a non-communicable disease. You're not getting it from another person.
Right. Right.
But yeah, those communicable ones all happen somehow, and they have basically routes of transmission. And those are the
Right.
things that we keep in mind the most. Is not necessarily the specific diseases because there's so many, and some are more virulent than others. Meaning like
More easily transmissible.
more easily transmissible.
Yeah.
But what we do is we make sure that we're aware of the routes that
Right.
can come through, and then we take the appropriate precautions for it. So
Well, and the big thing about that is like you said, we're not there on the EMS side of the house. We're gathering information, and so oftentimes you're not going to have the ability to make a determination unless something really sticks out to you about a particular disease or infection. You're not going to have the ability to make that determination in the field. You just know that something is going on, and it may be an infectious disease, right? But we don't have labs. We can't do
Sure,
blood
yeah.
draws generally in the field and have some sort of lab work done. And so that's why we, again, we're going to talk about it later. But that's why we take those universal precautions and wear our protective equipment, and because you just don't know. You don't know what you're dealing with.
So I think the biggest one that we worry about most is direct contact. Like in terms of every instance ever, like it is drilled into the EMS mindset. Like it's almost a trope, right? Like BSI seen as safe. Like when you're talking BSI, body substance isolation,
right?
99% of the time, there is only really one thing that you're wearing in that instance, and that's gloves. And gloves are really there to combat the direct and indirect contact. So like the things that are on a patient, you know, keeping their blood, their bodily fluids, the things that could be on them from getting on you. You're usually touching patients with your hands. And then, you know, after you're done, you're taking those gloves off and you're washing your hands to try and stem off any chance of getting, you know, a direct or indirect contact, because indirect could happen from you know, anything that patient's touching going to something else, or even things that are used within them. So like, you know, they're like nasal adjuncts or needles can have infectious diseases from them, which then they carry on that item, right?
Right.
So direct contact, we're taking those precautions. And I will say, like, while there is always that risk that exists, I am very comforted by the fact that I know those just taking the quote unquote standard precautions of the, you know, wearing gloves, washing your hands, and then like upping your PPE, like if you suspect more things of happening or needing more protection, is proven to be very effective. Like super effective.
You can, just by taking those steps, you can eliminate the majority of the risk to yourself. You know, now there's some specialty cases with certain, you know, infectious diseases that require even more than standard precautions. But just the steps that you mentioned with gloves, washing hands, and then, you know, kind of escalating our protective equipment as appropriate, we can eliminate, like I said, the majority of that risk. So
like and most of the things that are the scariest stuff, you know, are all kind of like that direct contact, right? But then there is that kind of world where it's like no matter what you put on your hands, it can get past that into the air. So like there's two categories of things that are beyond just like touch. So like there's the respiratory droplets, which are things that are like, this is where coughing, sneezing come in, where it's like, you know, the body's expelling these little things through the air, and they can either get into your respiratory system or onto things that are near your respiratory system. So like they get past the gloves, right? Like it's easier to get past the gloves. And that's where we start worrying about things like influenza and, you know, the ever, you know, popular plague that, you know, took over the world of COVID-19, where it's, you know, these things that like the boogeyman, like those things that we realize that like, oh shoot, like those that like just taking the standard precautions, just having the gloves on is not enough. Like those things get past that. Right. So,
and I mean, I worked all the way through COVID on an ambulance, and man, it was truly one of my biggest fears at the onset. You know, we like to make movie references here, and I saw Outbreak as a kid, way too young to be watching that movie. And it kind of instilled a fear in me for a really long time. And having worked through a global pandemic at this point, it's like, okay, well, you know, if we do the things we're supposed to do, we can most of the time be all right. So, but yeah, respiratory droplet protection is a big deal. We were talking earlier about, you know, masking, not masking, you know, all that sort of stuff. And regardless of where you fall, there, to some level, having a mask on is a positive benefit as far as PPE, especially if you know, flu season or, you know, known COVID infections and things like that, right? Like these are benefits. These are precautions that we definitely want to take. Um, just because we have to stay healthy so we can continue to provide service.
Yeah. Yeah.
So,
100%. Like, and also sometimes just knowing and understanding how those things work, right? Like, when somebody coughs, they sneeze, whatever, like droplets have sizes, those sizes, like those elements themselves can be stopped by materials, different types of masks and things, stop different particle sizes. So like nothing is the perfect thing that will stop everything, right? Unless you're in like a unless you're in the outbreak suit.
Yeah.
Right.
Right.
By the way,
air supply.
I love that movie. Dustin Hoffman kills it in that movie.
Oh, man.
Donald Sutherland,
Cuba
Gooding Jr.'s in that.
Yeah.
Oh, and the dude from House of Cards, Kevin Spacey.
Yeah.
Renee, not Zellweger, is it?
I don't know.
Renee Russo.
Okay. Yeah.
This is the part where I love movie trivia. Like, and like the do you remember the name of the drug, or it's not the drug, the virus in that movie?
I don't off the top of my head, but it was a viral hemorrhagic fever.
Yeah, it was African Mutaba.
Yes.
Mutaba. Yeah. And it changed vectors, or it changed.
It did.
It was because before it was something that required direct contact.
Right.
And then it evolved into a respiratory disease.
Right.
And I remember going through COVID and just being like, I've seen this movie. Like this is where they start locking down towns, and then like they bring in the thermobaric device and blow up the town with the thing. Yeah, I'm like this is it. Like this is I was worried.
Scary.
This is scary.
It was a scary time.
Do you ever look up?
It really was.
You ever look up the diseases that those things are based off of, the hemorrhagic fevers, like the Marburg virus?
Yeah, Marburg virus, and it's very lethal. The benefit,
God.
The benefit is because it's so lethal, and it's so lethal so fast.
Yep. It can't. It has no incubation time.
Yeah.
So it's
or very very little.
Very little.
So,
yeah.
So, but
it hasn't gotten airborne yet. So
with air travel, right? It's very easy for somebody to be in one part of the world where that's a prevalent thing and show up, and the CDC keeps track of all of those different things that pop up occasionally. It's an interesting thing.
Yeah, same thing with like Ebola. I think it's kind of in the same category of diseases.
Yeah.
So, and we've seen that happen. And I mean, this, I know we like to joke around a bunch, but like, if you look at the way that, modern society is able to respond, track, and kind of treat and, basically come up with a plan for those types of things, you can see like precautions and responses work to limiting outbreaks and everything from the PPE that's used in those environments to travel restrictions and tracking and making sure that, we're keeping an eye on those types of things to create alert and get things in place that need to get there. So it's I don't want it all to be doom and gloom. Obviously, it's things that worry us when we see them happening, but like, modern science and medicine do a really good job at doing the things they need to do for these.
Here's another obscure movie reference. It's a kid's movie, and I remember watching it as a kid. But this goes back to the indirect, or maybe even the direct, contact. The Scarlet Rabbit. Do you remember that cartoon movie?
I do.
Yes,
man, I don't remember. I remember the name of it, but
the kid in it was sick. He had scarlet fever.
Yeah,
and he had this stuffed rabbit that like kind of comforted him through this, and
yeah.
And at the end of that, all of the linens and basically everything the kid had was going to be taken and burned. And the happy ending of the movie is that the stuffed rabbit gets turned into a real rabbit magically.
Yes.
But I remember watching that as a kid, and I was like, okay, there's something I didn't quite understand it at the time, but it's like, oh, okay, some of these objects out here, these permeable surfaces, they can hold, bacteria and viruses and hang on to them.
But yeah, so respiratory, obviously, like that's a big concern. So there's some that are droplet size that are harder to get. So like influenza, and then there are some that are like super tiny, like aerosolized type, viruses, things that are very virulent, like TB, tuberculosis, measles. Those are a lot easier to transmit to other people through the air. They stick around longer. They're smaller particles. So it's kind of the same thing. It's like the body's expelling stuff into the air, but some of them are much worse than others. So the TB and measles are kind of in that category of like, yeah, you really need to make sure that you're wearing a mask or have some level of protection on for your respiratory system when you're around that. Like 100%. And those, like, there's a high chance of getting it if you're not doing that.
Yeah. And I mean, like the antibiotic resistance of some of these things, tuberculosis is a good example of that, right? Like it was very treated. There was a period of time where, we had sanatoriums where we would isolate these people with these different diseases, and tuberculosis was one of them. And, we got away from that because we could start to treat it with antibiotics, but now we're starting to see resistance to the antibiotic drugs that we have. And tuberculosis is one of those. So.
I watched a fascinating YouTube video on tuberculosis recently, and how it had a huge impact on culture in general, like fashion and like in the 1800s ish, where it was fashionable to be like, it's where we saw like people really getting gaunt in popular culture. And that's where like the term consumption comes in. Like that was a term for TB was, it's consumption.
The consumption.
And, and like people would look at it favorably. Like they were people who went out and actually, like purposefully got tuberculosis. It was so fashionable to have tuberculosis that it influenced makeup. Like people would wear, darker eyeshadow, like to have that kind of like gaunt, consumptive look. Look it up. It's absolutely fascinating because like it became so ubiquitous to culture, and then it had that kind of like very odd effect, like because people would lose a ton of weight and they would have this kind of like, it would eat away at them, like because they just it was one of the side effects of TB.
Again, another movie reference, but also an American history reference. When I think about tuberculosis, in my mind, the most famous
Doc Holliday.
Doc Holliday.
Yeah, 100%.
Doc Holliday. Yeah. So that's an interesting kind of tale. If you ever wanted to look that up, learn about Doc Holliday.
We should have done just movie references for every single one of these like vectors, and we're going to talk about diseases too. I bet you could find a movie reference for every one of them. While you mentioned Doc Holliday, is it "I'm Your Huckleberry" or is it "I'm Your Hucklebearer"? Have you heard the controversy between it?
I have not.
Oh, okay. So, man, we're going deep onto some random trivia here, but everyone thinks that it's "I'm Your Huckleberry," like the huckleberry fruit, like I'm your favorite, or like that's one. But it turns out back in the day, the handles on a casket are called huckles. So a lot of people will argue that he was saying, "I'm your hucklebearer," like I will bear your casket. Like
interesting.
I'm your ride or die homie. Which almost, I mean, that sounds even better, honestly. But it's I'm your huckleberry.
Yeah.
Doc Holliday is amazing, by the way. Like he's best character in both Wyatt Earp and Tombstone.
Yeah.
Where the hell we're talking about tuberculosis, airborne spread. Those obviously are harder to defend against. So you making sure you're covering up respiratory systems for stuff spread through airborne means. You got foodborne and waterborne illnesses. This is the things that we see in kind of less fortunate countries where they don't have access to clean water. We see E. coli, norovirus, amoebas, and all these other things that cause infections in the body.
Here's an interesting thing. A good portion of the urinary tract infections that occur for folks are often caused by E. coli. Right? We've got E. coli just kind of hanging out inside of us.
Yep.
At low levels sometimes, and sometimes you get transmission from one part of the body to another part of the body, and it causes issues for us.
Yep. Yeah. So make sure you wash your hands when you poop, you gross people. That's how it spread. Some things spread that way, man.
Yeah.
Like the foodborne, waterborne, like that is a vector for certain diseases. We have the vector-borne. So these are this. Oh, my chair just collapsed. Oh man, now I'm all flustered. So we have our vector-borne diseases, which is kind of like taking something completely out of the equation and bringing it in and going, hey, we're just going to mess up your day. Like, this is why I don't think mosquitoes should exist. Like, I don't see an evolutionary benefit to having mosquitoes around us, but like they're like one of the biggest vector-borne illness things ever with West Nile, Zika. Zika was huge like a few years ago. I remember we were looking to travel, and like we didn't travel places because of the risk of Zika, and we were planning a family at the time, so we didn't want to risk the possibility of having birth defects, because that was one of the things that was prevalent with Zika. But malaria,
that's a big one, man. Like, malaria still kills countless people every year.
Yeah, it's huge. Like, anywhere you have mosquitoes, you have people dying of malaria.
Yeah.
And granted, they have all different types of like drugs nowadays that can help fend off malaria, but still, like, it kills millions of people. Like, fucking mosquitoes, man. I hate mosquitoes. Like,
man, unfortunately, they're a big part of like the ecosystem as far as like lots of things eat mosquitoes, which I love those things.
Yeah, I guess bats are cool, but mosquitoes, I could live without those. Ticks. Yep. Also, I mean, really, any of these things that fall into this vector-based like disease thing, like, I don't like. They can go F off. Yeah. Honestly, like, did you hear about this new Lone Star? Is it Lone Star disease?
It's a Lone Star tick that causes alpha gal. We think we talked about it just a little bit on previous episode, but basically develop after being bitten by the Lone Star tick. You have a chance to develop this alpha gal, and it can cause you to be allergic to certain proteins and like in red meat.
Yeah,
and Rocky Mountain spotted fever is another tick-borne disease. Hey, here's one. Fleas, one of the biggest things in our history as human beings, right? The Black Death, the plague.
The bubonic plague.
The bubonic plague spread by fleas.
Fleas on rats.
Yep.
Yeah, they thought it was the rats, but it was the fleas on the rats that...
Well, they thought it was the cats.
Then the cats,
Yeah. And so... The cats were taking care of the rats that had the
Let's get rid of all those cats. Why are things getting worse? Yeah, I mean, like, there's so many different ways. I mean, technically, when you really think about it, the all of those, like, the vector-borne ones where it's like ticks, mosquitoes, fleas, or whatever, they're kind of like just sentient versions of needles. So it's kind of like secondary transmission that just flies around on its own.
Yeah,
because it still needs to come from another person, right? Like, it's something that's drawing blood or bodily fluids from another person, and then taking it and bringing it to somebody else. This, it's amazing what nature has come up with to just mess up your day.
Yeah, It's a big cat and mouse game with science and the rest of the natural world trying to get after us as human beings.
So yeah, those are the ways that that things can get around. Like we talked about, those are from our book, from the classes that we've been in, the different kind of channels or routes of transmission of diseases. But what about the diseases themselves? Like, we had to learn about some of those as well. Some things
Yeah.
that we need to keep an eye on. Now, granted, we may not be treating all these, like, but seeing them and being able to relay that to the hospital,
Mhm.
to higher levels of care, can be very useful. Also, it helps us in knowing, well, how much precaution should we be taking,
Right.
like, either from a symptom standpoint or knowing the disease. Uh, you know, and I would say it could even help from a social standpoint, in terms of like advocating for things like, flu shots. They do cut down the numbers of people that have influenza in society. So, like, telling people, hey, you should probably get your flu shot. But that was the biggest one, which, honestly, if you look at like the grand scheme of things, influenza, I believe, still is on like the top of the leaderboard for number of people that it has killed in history.
Yeah.
With tuberculosis being a very close second, if I remember correctly from reading Wikipedia. Because influenza is attributed to, well, the Spanish flu in like the 1900s, like, killed like a quarter of the world's population or something like that. It was crazy. Like, it wiped out so many people, like more than the plague.
Yeah. Yeah. I mean, even now, the flu, right? We think about, oh, I got the sniffles, I got the body aches, I got a fever, cough. Uh, but I mean, the flu still kills a lot of people every year in the United States.
Mm-hmm. And people that are, more susceptible to it, young children, the
Yep.
elderly, and, these, again, the flu is something that can develop into sepsis. Like, all these things that you can get, infections from, if your body just can't keep up with it and it starts spreading, that can lead to systemic infection.
Yeah.
We talked before about COVID.
Yeah.
That was I think it's going to like, aside from the medical aspect of it, which was, I had it twice and it sucked. Like,
Yeah.
it's rough. Like, I've had the flu before, and this was legitimately worse than having the flu. But it came on real fast and it left real fast. The flu was kind of malingering, but it's different for everybody, right? And then, the number of people that were having complications from it and comorbidities, like these,
Yeah.
that's where I think diseases really come into play. Is like, okay, relatively healthy person, yeah, it's not so worrisome. But the people that we deal with, especially in EMS, like, how many of your calls, Jonathan, deal with elderly patients from nursing homes that have, diabetes, congestive heart failure,
Yeah.
like COPD, all these.
A majority.
Yeah, pretty much
a lot of them.
90%. Like,
Yeah.
that's 90% of my calls that I've seen are like elderly people that are already sick, and then it's kind of like something else is now starting to add on to it, and some of them have been probably fighting off some form of infection, a sickness. So that's the straw, right? The straw that's breaking the camel's back can be these viruses or these illnesses, which often, another big one, pneumonia, right? Like,
Yep.
and I think there's a bunch of different forms of pneumonia, but essentially they're all kind of like, they're all that kind of infection in the lung where it's like a coating of bacteria in the lung.
Well, it could be bacterial pneumonia, it could be viral pneumonia.
Right, yeah.
Pneumonia more or less being the condition, not the specific pathogen.
Yes, yeah.
Yeah.
So different forms of it, but it's essentially that infection of the layer right inside the lung itself. And we're, that comes with some symptoms too, like, crackles and rails in the in that you can auscultate and listen to in the lungs. But pneumonia, like we saw in Jim Henson, can lead to sepsis, like one of the big ones. Um, tuberculosis we talked about. That one's really like, I can't stress this enough. If you suspect tuberculosis, and I know we hardly ever see it in today's world. I remember being a kid and getting the TB test. Did you ever get one of those? The little skin
I
prick?
so well, and I haven't had they call it a PPD. I'm not sure what PPD stands for. Somebody out there probably knows, um but yeah, I've had that working in healthcare. About every time I go and get a job in healthcare, they want to test you for
Mm-hmm.
tuberculosis. Now, the last two times I've been tested, I got tested at the beginning of paramedic school, and then just prior to the start of this contract, I got tested, and they do it through a blood test,
Mm-hmm.
quantiferon blood test, and that's easier, right? Like because they just draw the labs and then they send it off and they let you know.
Yeah, nowadays I
But
assume it's way easier just to do actual
yeah,
blood
but the
tests.
PPD, you had a time frame where you had to have somebody come in, like you had to go and get it read. It was a scheduling nightmare, but um, they want to make sure that if you're going to go into these environments, you're not spreading tuberculosis
Right.
because we deal with sick people.
Mm-hmm. And you they want to make sure you don't have it, but
Right.
it's one of those ones where, like, if you suspect it, you
Hmm.
really want to make sure that you're wearing a mask, like,
Yeah.
to
Yeah.
protect yourself and to protect others around that patient, like limiting contact.
Yeah.
Making sure everybody has a mask on, turning the vents on in the truck to like ventilate the air. Like
Yeah.
they go through a bunch of stuff with you to kind of tell you what precautions you should take, and then obviously, like we're doing with sepsis, like it won't hurt to kind of call ahead on that side too, to be like, hey, we have a suspected tuberculosis patient coming in.
Yeah.
What would you like us to do?
Yeah. Hospitals do not like when you roll a possible tuberculosis patient through their ER without taking precautions
Right.
first, because what did you just do? You might have just exposed everybody to tuberculosis. It's been several years, but even here locally where I'm at, we had a case of tuberculosis, and that guy was very, very sick. And it got reported to the Department of Health and to the CDC, and all these different things that happened after the fact of
Mm-hmm.
exposure. And so yeah, I mean, it's definitely not something to play with. Well, like I said, we don't see it as much anymore, but it is on the rise.
Yep. Um, Another one that we learned about, which is actually, this is the one where growing up, I was like, oh, that sounds terrible.
Hmm.
Meningitis.
Yeah.
And while I think there are multiple forms of meningitis as well, viral and bacterial, like, the types of communicable diseases of meningitis can happen. And that's that's a brain infection, or it's not really a brain infection. It's an infection of the
Meninges.
meninges that's like surrounding the brain.
Hmm.
So they're just really bad. Like, you don't want meningitis. Like, that is deadly. And can be very infectious.
Right.
Meningococcal, I believe is the pathogen.
Hmm.
So that, looking for some red flags of that, like headache, fever, and neck stiffness. The combination of the fever and the neck stiffness being, a
Yeah.
red flag for meningitis. And photophobia. Those are you just want to make sure that if you're seeing those things, you're like, that doesn't seem right, or a rash can happen with it too.
Yeah.
Is making sure that somebody, like, hey, if you notice that, tell somebody right away, because that could be something that needs really quick treatment. But yeah, meningitis is bad, and then the one that scares the hell out of me is MRSA,
Yeah. Yeah. And
MRSA.
yeah. And I mean, we see a lot of hospital or healthcare acquired MRSA.
Mm-hmm.
You know, it it's really it, and that, the thing of it is we have, you know, I'm gonna butcher the pronunciation, staphylococcus. We have that pathogen kind of just on us, and it's around us all the time.
Mm-hmm.
It's on your skin, just hanging out. and sometimes it turns inward and becomes a systemic infection. And MRSA being the antibiotic resistant.
Yes, that's why it's scary. So, like, for the uninitiated, Staphylococcus, sometimes abbreviated to staph, a staph infection. It's usually what people refer to, like it's why people don't want to go to hospitals, because they think they're going to get a staph infection. That's where they're very closely associated, but they can happen anywhere, right? Like it's kind of like like you said, it's a surface level bacteria that can just, you can get it from anything, but the people most commonly associate it with getting them in hospitals.
Right.
And staph infections are bad, but MRSA is the medication resistant form of staph infections.
Right.
So like it's evolved. Like it's like, it's in human development. We've tried coming up with ways to stop this, bacteria. And it says, no, we're gonna stick around. Like, and then it's like, there's only so many things you can throw at it. Like, and then it's good.
It is not something to play with.
No. Is that the one? I believe they call it the flesh-eating disease, right?
That's its own sort of bacteria. Yeah. Yeah, no, that's its own.
Oh, that's necrotizing fasciitis. Never mind.
Yeah.
But like it's a skin infection, like with MRSA, and it leads to these like sores and like it's real bad. What else? What else we got?
So hepatitis, right? So yeah, we've got a bunch of different strains of hepatitis. The root word being the hep, right? The hepatic, the liver, right? It has liver involvement, and inflammation of the liver.
Yep.
Right. So the most common ones we're going to see are going to be hepatitis A, which is food, waterborne, fecal oral route.
Yeah.
Oftentimes it usually comes about because somebody is infected with hepatitis and they're preparing food and they haven't washed their hands. You can be vaccinated against that. It's not a common vaccination, but there are places around the world that if you're going to travel abroad that you would want to get vaccinated against hepatitis A. Hepatitis B, we don't hear as much about it because there are vaccinations for it.
Yep.
But yeah, that's more of a bloodborne pathogen, and so most school systems do require kids get those. I got those vaccinations as a kid. It's like a series of 3 different shots, and it's not as, it's a big deal if you get it, but like with being vaccinated, it's not as big of a deal. And then we've got hepatitis C, and up until pretty recently, there was nothing you could do for it as far as like a vaccination or anything like that. I don't believe there's still a vaccine for it, but they do have some different treatment routes for it now.
Yep. It's actually curable now.
Yeah.
It's so I in my other career, in pharmaceutical advertising, I worked on a hepatitis C drug for like crazy 5 years, a cure. And it's interesting to see how that works. And basically it just, gets you to a viral load that is below like, the levels where it's detectable for a certain amount of time, and then you're considered cured. But there is a cure for Hep C. A couple of companies make one, but it could be a bit rough, and coverage was a big issue for like insurance companies, because of course they charged like $70,000 for it.
It's very expensive.
Yeah, it was very expensive. However, it's it's an odd disease because obviously it kind of affects the liver, but it can sit dormant for like a very long time.
Right.
So, one of those things, I mean, just for people out there, I learned this myself. like advocate for your parents or like if you're if your parents or your grandparents are in that kind of baby boomer generation, a lot of them could have been exposed to hepatitis C when they were younger because it was not always in things that like, you know, blood transfusions. They didn't look out for that type of stuff back in the day. So even people who were not necessarily like intravenous drug users or, you know, because it could also be sexually transmitted. But like back when people would get blood transfusions, they could have been, you know, exposed to Hep C, and it lays dormant for 20, 30 years. Yeah. And so you don't really see the effects of it until that generation gets to like the 70s or 80s, where they've had it for so long, and then all of a sudden it compounds and creates like liver cirrhosis and liver compromise and all this other stuff. But yeah, they don't, even if they knew you had it when you were younger, they often didn't really treat it because it didn't have any ill effects until it kind of like ramps up later in life. So it's weird what diseases can do, how they can kind of, you know, just linger around. Yeah. Like herpes. Like herpes is one of those things, another kind of sexually transmitted, or not just sexually transmitted. One of those, it can be direct contact.
Direct contact.
Yeah. To mucosal membranes and like your mouth or, you know, other your eyes. Like it's one of those things where it's like it pops up when you're stressed, or is like, you know, some people call them cold sores when they have another disease coming up. They'll get like a sore on their lip. Oh, it's just a cold sore. Nope, that is herpes. Like
it is.
Yeah. It is. Same herpes, by the way. Same herpes exists in both places. So like, you know, knowing those things, like, and talking about them, like I didn't know that as a kid. Like I didn't know that growing up, that like, you know, cold sores are the same thing as like genital herpes. So,
well, there's type 1 and type 2,
but
herpes.
Both can exist in both locations, and one of them is more susceptible and more likely to be found in either location. But they both behave the same way. It just depends on which one you have.
It's just a different strain.
Yeah.
So, I mean, all sorts of things that you know. That you want to protect yourself against.
All these things. And then with the hepatitis stuff, you know, I think one of the I mean, it's just such a big part and part of the story, at least in my life, of growing up in the 90s of like that kind of epidemic of AIDS and HIV. It was the boogeyman for so long of the thing that we always look to go like, oh my God, that's going to ruin like the world. Like it's so many, like it's going to kill everybody. Like it's the plague. HIV nowadays looking at it and going, oh, well, thank God modern science has figured out how to how to treat that, because people with HIV, like that used to be especially AIDS, it developing into the AIDS syndrome. But HIV used to be like, oh, you know, you're that's it. You better start like, you know, making arrangements and putting your, you know, saying goodbye to everybody. And
it was very much like that for a very, very long time.
Scary.
Yeah, and I mean, like HIV is still a serious, you know, infectious disease, but the interesting thing to me, as I learned, was and prior to some of the more modern treatments for both Hep C and HIV, hepatitis C can live on surfaces outside of the body inside of like blood and different fluids for, you know, a long time. You know, all things considered, and you know, HIV is not like that. You know, it's more of a direct contact with, you know, some sort of infected body fluid or whatever to the mucosal membranes. But I mean, it can't live outside of the body.
Yeah, it is
like Hep C can.
It is not as virulent as Hep C. However, I think the biggest transmitter of both isn't necessarily the sex. Like it was always the stigma of it being like a sexually transmitted disease, or I think they call them STIs now, sexually transmitted infection, not a disease. But The intravenous drug use, which
that's a big one.
Is huge because it's often communal, like people sharing needles and then, passing them around or reusing needles. And it's like, that is like almost an instant, like, way of transferring these diseases. Right.
Yeah.
It's not really much more of a direct way. Like, hey, it's in my blood, I'm going to put it in your blood and we'll share this needle.
Once upon a different life, I was in law enforcement for a period of time, and did most of my college education in the administration of justice, and took a class on drugs and drug use and kind of how that plays into law enforcement and that sort of thing. And one of the things that I learned, and I didn't know this at the time, but when people are passing around a needle, oftentimes they will aspirate some of the blood into that needle. It's not just the needle; they'll aspirate it into the syringe to make sure they're in the vein.
Mm-hmm.
And well, of course, if you're pulling blood into that needle and then you're passing it to the next person,
yep.
It's I didn't realize that until I learned that in that class. That was part of that process that a lot of people undertook when they're utilizing IV drugs.
Right. Yeah, there's so many things about that the intravenous drug use, like, aside from the implications it has on overdose and like just people, falling victim to this kind of blight on society, it then has this secondary effect too of like spreading communicable diseases.
Yeah.
It's like, just, how many more ways can it screw us? Drugs. But yeah, so like a lot of different ways. The last one on here was GI illnesses.
Right.
So again, kind of in that same vein of direct contact, but it's like, they involve vomiting and diarrhea. So like, bodily fluids coming out of the body, and then like, obviously that being a vector for diseases getting to other people. So like, stay away from other people's vomit and diarrhea. Like that, it's a good strategy, usually.
I mean, the other aspect is like food poisoning, right?
Yeah.
That's not necessarily an infectious disease per se, but like that's definitely something that we, food poisoning is it's not necessarily poison per se. It's some sort of virus or bacteria that has made itself onto your whatever you're eating, and has colonized enough to cause illness.
Yeah.
And man, I don't play with food poisoning because I don't like having GI issues.
Oh, man,
I hate it worse than anything. I'd rather have the flu. Knock on wood.
On one hand, I can count in my life times where I've had like true food poisoning, where it's like I've eaten something and it's just like everything needs to leave your body all at one time.
Yeah.
Man, that is a bad day.
Yeah. So I don't mess with GI illnesses. I mean, as far as food's concerned, if it's even a little bit hinky as to how long it's been out to room temperature, I pitch it. It's not worth it.
You're not a fan of like eating like an egg salad sandwich that's been sitting out like all day?
No.
No gas station sushi for you?
I draw the line at gas station sushi. Kroger's has got some pretty nice sushi. But I've seen some sushi in Sheets, and I'm like, no, this is where I draw the line.
Sheets sushi, no. But if Buc-ee's had sushi, I'd eat it. I would. I implicitly trust anything from Buc-ee's because I just have an affinity for that. Have you been to a Buc-ee's?
We've got one probably like 90 miles from here, and so I you know what? When I come to see you, I'm gonna make a pit stop.
Wait, have you not been inside a Buc-ee's
I've
yet?
never been in one.
Oh my God, sir, you. To anybody listening out there, if you have the opportunity, if you pass one of these shrines to modern travel, you must stop and experience the wonder, the modern wonder that is a Buc-ee's. Like, they are, first off, I don't know how long we've been going on this, and I know this is a tangent. We got other stuff to talk about, but just fuel pumps for days, a floor plan that rivals like the inside of a Walmart in terms of space. like every food and junk food imaginable that you could ever want, like soda fountains that line the wall. Like you have, like if you were to draw the space, you would have to use perspective to like properly show how many soda fountains there are along the wall into the distance. Like it is, it's like, it's huge. And they have really good food, and they have fudge, and they have like beaver nuggets. By the way, if you ever go to a Buc-ee's, you have to get the beaver nuggets.
Okay.
All right, I'll get off Buc-ee's, but yeah, you have to go. Stop at a Buc-ee's.
Today's sponsor for the RideAlong EMT School podcast has been Buc-ee's.
Yeah,
or we wish, maybe.
Yeah. Oh man, that would be amazing.
I work for Buc-ee's in marketing. Please call us.
Yeah, I really don't like travel, like road travel. Like but like there are certain things I just latch onto that give me like some level of joy, and the absurdity that is Buc-ee's is one of them. So, but yeah, so like, there's a lot of where the hell were we? We were talking about the
GI illnesses.
Yeah, and the ways that you can get diseases. Okay. So this next section we've talked about a bunch, actually. It's our prevention, right? Like, and we've talked about this so much on previous podcasts that it would almost, we don't need to go through it all again, but like the idea of the standard precautions, like the BSI, body substance isolation, safe BSI for, or for my crew, my partner and I, like those are the things that we ingrain into ourselves. So gloves, hand hygiene, upping up the protection to, eye and face protection if there's any chance of some sort of aerosolized, stuff getting into the air, and masks for respiratory illness. Like those things should be ingrained into you, and you should never feel embarrassed and or hesitant to grab one of those things and up your protection if you need to, based off of what you're seeing. Like if you see somebody with a cough, put a mask on.
Yeah.
Right? Like you don't need to bring that shit home. Like, and if it helps protect you, you should use it. Respiratory, but like you can up those things even further. Surgical masks are obviously kind of a base level where we all learned how those things work in COVID. Everyone was wearing masks.
Yeah.
Are they 100% effective? No. Like, I think science proved that, but are they more effective than nothing? Yeah. So, why not take whatever precautions you can, to protect yourself. And then N95s, P100s, like respirators, like, if you really start suspecting things like tuberculosis, those are the types of things I would advocate for putting on and saying like, hey, I'm not, I need to be very careful about making sure I'm not getting these crazy things.
Right.
So like respiratory protection is important. And then, there's a reason. So there's another form of thing, which we haven't actually really talked about yet much, I don't think, in any of our previous episodes. And that is that like red plastic box that's usually like hanging on the wall in the ambulance, or like tucked next to the trash bin in the ambulance.
Yep. Sharps containers.
The Sharps container, right? Like we should, you should know where that is, because anytime you have something that's Sharps, it should go into that container.
Yeah. So that would be anything that's got a needle to it. That would be, so obviously needles, potentially even your lancets for your glucose checks. That might be a razor that you use to shave somebody's chest before you put on an EKG, right? Yep. There's a blade in there that needs to go in the Sharps box. I mean, and like there's some good practices that you can take with the Sharps box or with Sharps in general, because we deal with Sharps on a regular basis. I like to call out my Sharps, right? Be like, and if I'm passing a Sharp, ideally you would put your own Sharp in the Sharps box, but sometimes it has to be, something that you pass to somebody else to get it to a safe location
Sure.
in that sharps box. But that has to be a very deliberate maneuver, and you have to communicate that. So, and then there's sometimes where it's like if I'm in the back working by myself, and my partner's up front driving or doing something, and I may not have access where I'm sitting to a sharps box. I always make sure that sharp is very, very apparent, and then I let my partner know, hey, there's a sharp back there, right? You got to communicate that. Man, sharps boxes, that's a thing. Hey, when I talk to the old timers, if you've been in EMS for longer than 20 years, you probably remember before sharps box existed, or they were widely utilized on ambulances. Guys used to stick their needles, because we have safety needles now, but guys used to stick their uncapped needles in the bench seat of the ambulance, that cushion. Yeah. To like prevent the sharp from just kind of floating around. Yeah, not a good practice. So I'm glad we've gotten away from that.
Yeah. Yeah, I'm thankful that a lot of the stuff nowadays actually comes with like, self safety things, like, maybe not even just the retracting needles, because I can imagine those being, annoying every now and then, like, because it requires you to like grab another one if that safety needle kind of falls back in, or but like most of the needles nowadays will have like a bend over type of like safety cap where like it folds over the side, so it's immediately available for when you're done using it. You put that safety cap back on instead of having to like do the, all right, let me get this needle into this tiny little like cap while I'm moving.
Yeah,
that,
we should not. Yeah, generally we should not be recapping needles.
Sure.
Yeah, we should not be recapping needles. We should use them and then dispose of them properly as soon as we're done with them. And if you're Mike, this is I was watching you do it as you were describing it. If you're watching this on YouTube, we don't want to close those safety needles with our thumb, right? We want to use a hard surface versus like pushing the safety cap over. Yeah, that's a good way to get stuck.
Yep.
Here's another sharp that I almost missed, and we kind of talked about it in our last episode with anaphylaxis, but ampules or vials, right? We're dealing glass.
Yep.
Yeah, so glass needs to go into the sharps container when we're done with it, and then obviously it's a if you're cracking an ampule open, there's a proper procedure for doing that, right? You utilize a gauze pad to kind of protect yourself, or sometimes they come with their own gauze pad to utilize as you're breaking that ampule, and there's a proper direction to break them. But sometimes those don't break very cleanly, and they can cause issues. So you got to be careful when you're doing that, and that's a possible route for infection. So just keep that in mind as you're handling sharps and glass and everything else.
Yeah. Yep. Don't recap needles. Like that's
recap needles.
Bullet number 1 under the needle stick prevention is don't recap needles and use that sharps container. Like that's, if you can follow those things, I think you're doing pretty good. So, and then last kind of thing in that category of staying safe is cleaning.
Yeah.
But nobody ever cleans an ambulance, right? Like
we probably don't, as an industry, as a profession, we probably don't do as much as we should.
Yeah, maybe.
But yeah, we need to be cleaning and then also disinfecting, right? So cleaning is just, getting the dirt and
they're
the
not
grime.
the same thing.
Yeah, they're not the same thing. But getting the dirt and the grime up and then disinfecting, where we actually take some sort of chemical or use some sort of device to actually disinfect the truck as best we can, right? Yeah. We're not going to sterilize it because we can't utilize that much heat, but we can disinfect it. We can kill those pathogens.
You mean the back of the ambulance doesn't turn into an autoclave? Like,
No,
one of those buttons doesn't do that. Like, I still have not figured out what all the buttons on the damn back of the ambulance do, but
these things don't work. It feels like it's the first thing to break, but I've got a couple ambulances I've worked on where, they come with these UV lights, this, that, and the other, and you're not supposed to be in there because it could damage your eyes. And it's like, you know, I don't think they work personally. I mean, there's probably some science, but like the way that we utilize ambulances and all the stuff we have in them, there's no way that light penetrates everywhere it
Well, yeah,
needs to, right?
it doesn't go where there's shadows. Like
Right.
there's a whole section of places in an ambulance that don't see the light of day.
Yeah.
Especially under the thing that the patient lies on top of, like the actual gurney. But this is to say that with the process of becoming an EMT, I've noticed that is ingrained in the culture, right? Like, hey, we go do the thing, we drop the patient off at the hospital, we do a good patient handoff, and then immediately it's all right. Now let's move into the cleanup time where it's we're changing off the linen. We're throwing that in the used linen box at the hospital, wiping down the gurney. Luckily, all that stuff is made out of metal or vinyl surfaces, so it cleans up pretty well. We're doffing our gloves and like going back to the ambulance and then cleaning up anything there. So it's like it's part of the procedure, right?
Yeah.
Go right into the decon or the not decon, the disinfectant and the cleaning right after.
Yeah. If you've ever barehanded those purple topped wipes, go ahead and hit the subscribe button.
The purple topped wipes?
Yeah, there's a disinfectant wipe that has a purple lid.
Oh yeah.
Yeah. So
I'm colorblind, so they all look the same to me.
Oh, well, yeah, they're pretty ubiquitous in EMS. So the forbidden hand wipes, you couldn't be using them barehanded. Yeah.
Yeah. So we've gone through a bunch of stuff. We obviously talked about sepsis up at the beginning, the things that we look for in sepsis, why it's so bad. Because this was a big part of the chapter was like, really, they emphasized looking out for sepsis and calling a sepsis alert if it's necessary or if it's indicated very heavily and why it's important. The signs and symptoms of infectious diseases, but we all know these, right? Like these are things that we grow up with. We understand them. Fever, chills, cough, sore throats, all the signs of being sick in general, vomiting, nausea, like, and some of these things come into play with the other things we have to look out for. So like vomiting, nausea, every time we see something like that, we should be thinking about, okay, if that happens, what am I doing to help them with an airway? Because while the disease itself may not be something we as EMS professionals can deal with directly, the things that can happen to them are things that we can help with in case it happens, right? So making sure that airway stays open, making sure they're not bleeding, the ABCs do not go away just because they're sick, right?
Right.
So, and looking out for things like shortness of breath, like if they're coughing so much that they're having trouble breathing, well, that is something that we can help with in terms of adding some supplemental oxygen and just helping them be able to breathe to get them to the higher levels of care, right? Things for sepsis that we're looking out for, definitely that altered mental status. We had a whole episode kind of talking about altered mental status, keeping an eye on that because there's a bunch of different reasons that could be happening. One of which is sepsis. One of the, it could be low blood sugar, could be both. Who knows? You could have altered mental status, get a low blood sugar reading and be like, oh great, that problem is fixable. And then maybe it doesn't go away. Like maybe they still have altered mental status. Like, what? I fixed the thing. Well, they could also be septic too. Like it doesn't. They don't cancel each other out. And patients are a lot more complicated than I think the textbook makes it out to be. Like sometimes you just don't get that easy answer, right?
Yeah, they certainly can be for sure. It's not as always clear cut as the book makes it or your scenarios in school make it.
It's like no, you're not supposed to have two things. It's just one. You get one thing. But like looking out for things like the rapid heart rate, obviously that's a big, something we always look for. Fast breathing, the tachypnea, and this is the big one, right? Like you had mentioned it before, and like the end stage of sepsis or late stage of sepsis, I should say, is a low blood pressure.
Right.
So if you're seeing things like, a fever with that low blood pressure, that's like, oh, that's like sepsis. Like we should be calling that out for what it is, and making sure that we're paying attention to it.
Yeah, our service criteria that we talked about before, it only requires 2 of the things that we're talking about,
Mm-hmm.
2 of those signs or symptoms to trigger that.
Yep.
Right. So,
but 2 of those things, like a low blood pressure, high blood pressure, and like
it'd be low blood
pressure and a high heart rate, right?
Mm-hmm.
Those 2 things don't always necessarily mean sepsis.
Right.
Because there's a lot of things, just in general that those could lead to. But when you see that low blood pressure and a fever, that's one of the things that they emphasize of like, that is that particular combination, the fever shows like more often than not is kind of like a sign of infection. And if the infection is coming with low blood pressure, it's like, that's a big red flag. Right. But yeah, so sepsis, things to look out for, things that we can be doing as EMTs to kind of look for that. And of course, like the signs of shock, or things going from what looks like normal infection. So like warm, red skin, like, that kind of red.
Right. Streaking. Yeah.
Going to, hey, it looks like they're in shock. Like they're cold and clammy and looks like they're not, doing very well.
Right.
So that's a huge flag. And then I think, while we're looking for those things, obviously keeping an eye out for the primary assessment, the ABCs, the history side of it is especially when it comes to diseases, is where we have the most ability to kind of help investigate, to help get the complete picture. Like, obviously if a patient's non-responsive, we don't get any of that if they don't have somebody around them. But especially when it comes to disease, there are some easy questions that like will help kind of complete that picture, right? Like,
yeah.
Hey, have you been suffering from any infections?
Right. Have you been anywhere or been around anybody that's been sick, or have you traveled abroad?
Yep.
Yeah. Every time when I'm bringing a patient in, they always ask, hey, are you taking any antibiotics? Or in the last 2 weeks, have you taken any antibiotics? And then have you traveled anywhere in the last 21 days abroad?
Mm-hmm.
Those 2 questions get asked every time I bring somebody into the ER.
Yep. And especially things like, timelines can really help with that patient treatment of like, well, how long has this been going on? Like, how long have you been sick? How often have you been vomiting? Like, and what type of medications are they on? Like just helping kind of, like we mentioned in the secondary assessment episode, it's painting that picture, right? Like you're giving a more complete picture to the hospital and giving them the ability to treat well. So that's really, I think that's really everything we went through. Like there's so much in this, like there's so many different things to look out for in infectious diseases, ways they can happen, different diseases. And this was just scratching the surface. There's a million different diseases out there.
This is a broad overview.
Yeah.
We've talked about a lot, but I mean, there's so much we could get down in the weeds on all this stuff.
Yeah, the greatest hits album, if you will. Like, we're not getting into the B-sides, but this is, it's a very broad topic. There's, and I think part of what I was struggling with when I was learning this is like, okay, great. I'm learning about infectious diseases. Where do I fit in? Like when we first started talking about it, and then really kind of honing in on it and going, okay, my job in this instance is like the sepsis beacon. Like, like if something, if I see something that can be, raising the red flag, right? Like that's what I need to do. Like being there to be early recognition of sepsis and going, hey, we need to get you to the hospital. We need to let them know so that they can get you the care that you need. That's our biggest role, I think, in this particular, genre, and as well as obviously the things that we normally do in terms of making sure that in route while we're with that patient, the primary stuff is not failing,
Right.
making sure that we can get you there safely.
Yeah. I mean, that just like we talked about, that recognition, getting that history and making that, making that determination to trigger that sepsis or to call that sepsis alert. Those are big things. And then of course the supportive care that we can provide on the way to the hospital.
Mm-hmm.
So,
but yeah, so that's our infectious disease and sepsis. Typically this is where we would go into our tools of the trade. However, we are omitting tools of the trade in this episode because our faithful co-host Max is not here to do it. We had it all lined up too, but we've gone a bit late in this episode.
Yes.
And we were gonna we gonna talk more about this, but we were gonna talk about thermometers, and the different types of thermometers you can have. We will save that for a later episode. But know that it is an important part of this story, and you should know how to use your thermometer, so that you can help spot those signs of a fever. That's really the thing that we need to make sure that we all know how to do is we have thermometers available, know how to use them. Most of us have been dealing with those since we were young, and our parents would force a thermometer into our mouth to make sure that we still had to go to school. I remember trying to fake being sick, and every time that thermometer came in, I'm like, all right, I give up. I'm not that sick. I don't have a fever. I'm just sick. I'm just sick of school. She's like, that's not a reason that you get to stay home. Unfortunately. But yeah, so we're skipping tools of the trade this week, and we will come back at you with a bunch of information on thermometers in a later episode. But with that, why don't we move into our final segment from the man, the myth, the legend, the student tip of the week from Jonathan.
Okay, so Mike already touched on it a little bit earlier about wearing your PPE, not feeling ashamed about wearing your PPE or personal protective equipment, right? And depending on the class you're in, it might be called PPE or it might be called BSI, depending.
True.
Yep. I've seen different textbooks label it differently and it be taught differently. But the point is, you should be wearing your PPE. And in addition, and the last point I'll leave you guys with, wash your hands. You should be washing your hands before, you leave the hospital. After every call, after every patient interaction, you should be washing your hands.
Mm-hmm.
That's the biggest thing. That's going to help keep you healthy, help keep you on the truck, help keep you learning, help you keep you in class. Wash your hands.
Yeah, and you're doing it not just for you. You're doing it for everyone else.
Exactly.
Wash your hands. Gross people.
You nasties.
People who don't wash their hands. It doesn't.
Yeah. It is an important thing. Yeah. But really, wash your hands. It's one of the big things that help keep you healthy.
Yeah.
So
I like it. Yeah. Especially what we do. It's like we're around such gross stuff. Like,
yeah.
Just it's an easy answer. It's an easy way to stay safe. But yeah, so that's everything. I think that's our episode on infectious disease. Episode. Make sure you stay tuned. Our next episode, we're going to be dealing with poisonings and overdoses, which I'm sure we'll have some stories for. I know I do. I have one big story so far that deals with overdose, and I'll be looking forward to kind of sharing it with you all. So, yeah. Thanks for taking the ride with us, and we'll see you next time on the RideAlong. This podcast is for educational and storytelling purposes only. It is not medical advice or official EMT training. Always follow your accredited instructors and local protocols. Heartbeats racing in